you want to be a surgeon or a healthcare professional that performs any surgical procedure, the skills in this video are essential to good outcomes. In today's live session, I'm going to share with you the best ways that I've learned in the last 10 years working hospital during my surgical career on how to tie surgical knots, specifically how to tie with instruments and how to tie with a hand tie. So let's cover the basics to start with. I'm going to cover instrument ties. So as you know from some of our other videos, when you're loading your needle, the needle's body is here, the swage is where the suture thread attaches, and you have the point somewhere about here. You want to mount it about 2/3 along the body. Mount the suture, pull the packet away, don't pull the needle away out of your surgical field. So we're going to just lay a simple interrupted suture. Reflect back, don't pinch the skin. I can get across in one. Grab the body, not the point, otherwise you blunt it. Don't let the needle go out of your field of view. Pull, 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 pull. You palm the forceps. And then we're gonna do the first of 2 knots. So the first knot, when you do an instrument tie, should be a surgeon's knot. A surgeon's knot is a secure knot. So you place the needle holder parallel to your wound between the long and the short thread of the suture. You want to wrap it just around the tip, not around the whole body, and it's not a big movement. You want to have economy of movement and not use unnecessary energy. So just around the tip, 1, 2, grab the suture at the end and pull it through. That was a surgeon's knot because it was 2 revolutions around the needle holder. My sutures come undone because there's tension on the wound. So a way to secure that knot, pull the suture, keep the tension on the long suture away from me, and slide the short suture to the same side. That didn't hold, that did. And now I'm going to do a reef knot, which is a single revolution around the needle holder. So when we're tying our knots for simple wound closure, you do a surgeon's knot followed by 2 reef knots. Of course, we do this as always. Let's cover that again. We'll cover the 2 things we've just covered in that. So you go across. Don't grab the point, grab the body. Keep the needle within your surgical field. Put the needle down, palm the forceps. It's finesse. This is about finesse. It's not about just skill. It's about making things look like you've got control. So needle holder in between the 2 sutures. Wrap around just the tip, 1, 2. Grab the tip of the short suture, not all the way down there. Grab the tip, pull it through. This is not about strangulating the tissue. You just want epidermis to meet epidermis. Once that's happened, if your wound's going to reopen like this, you can hold the knot by sliding the short end towards the long end, and you can see the knot go across. If it reopens, you can try again. It doesn't reopen. So then a single revolution, 1, is a reef knot. And you want to make sure your short and your long suture always alternate. That's how you lay secure, square knots. You cut, and then you can do that if you know you're going to be cutting your own sutures. People say, why do you like this technique? It was only yesterday I was on call. I was suturing a thumb of a patient, and in A&E, I've got a little trolley which is no bigger than this. My sterile field is no bigger than this. You don't have the space that you have in theatre to be putting your kit down everywhere. I don't have a scrub nurse. I don't have an assistant. No one's cutting my sutures for me. So if I can be as economical as possible by palming my forceps, keeping my scissor here, if I'm wearing sterile gloves, I keep everything nice and confined. I don't waste time, looking for things. Everything's within my hands and within close reach. So we've covered the surgeon's knot, which is 2 revolutions around the needle holder, and we've done the holding throw to the knot, where you keep the tension on the long suture and slide across. The other type of knot, a way of securing and retensioning your knot, is the slip knot. The slip knot is not a secure knot. So we know that this is gaping, so I know that reliably this should reopen when I tie it. So 1, 2, that's the surgeon's knot. Tie it, it reopens. So what I'm going to do now is the slip knot, and as you saw, when you tie your knots normally, the short end and the long end should alternate. With a slip knot, the short end and the long end do not alternate. So you can see the position of the short and the long end. The short end is closer to me, the long end is away from me. So I'm going to tie a reef knot, and I'm going to bring the short end back down to where it came from and the long end back up to where it came from, because I want to retension that knot. So that's 1 revolution on the needle holder. Pull the short end through the loop, and now I'm going to just pull the short suture until the wound approximates. It is now approximated. Now I'm going to pull the long end. That's a slip knot, that's not a secure knot, and that's why it can retension. So now I'm going to do a secure square knot by wrapping it around the tip, grabbing the tip of the short suture, and letting the 2 sutures alternate position. To be economical, you put everything into your left hand. If you're suturing with your right, you cut. Now, you can do your sutures with, and your knots with just reef knots. There's nothing wrong with that. It's just not as secure as a surgeon's knot. So 1, 2, well, I said reef knot, didn't I? So 1, but it reopens. So I'm going to do a slip knot. I'm going to bring the short end back down and the long end back up. Pull the short till the skin approximates. It's now approximated, so I'm going to pull the long end. It does waste a bit of suture though. And I'm just going to put 1 more in between. I'm going to do it the standard fashion, which is 2 revolutions on the needle holder. Got some other tricks coming for you in a second. Palm the forceps. 1, 2. Just there. Make sure you haven't got anything in there. You need to swap positions to make it secure. Now, in terms of number of knots, when you're suturing with a monofilament, you need between 4 and 6 knots. When you're suturing with a braided, you want 3 or 4 knots. 1, 2, that's the surgeon's knot. 1, that's a reef knot. 1, that's a reef knot. So it's a surgeon's knot followed by 2 reef knots. So I'm going to now show you a trick for if you've got a wound under a lot of tension. You really want to maintain the closure once you've placed your suture, but you're struggling to do so. I'm going to show you how I do that. Again, you can see the needle body here, the swage is here. Grab it 2/3 along the way so you don't have to remount it, and pull the packet away, don't pull the suture away. So I'm going to go straight for the middle. Ideally, you'd want to put a layered closure, so a deep dermal. Then you put your superficial closure. Let's say it's still under a bit of tension. I just want to tack the wound closed because I know I'm coming back to do a procedure on this patient. And that happens a lot with debridements, or for example, the other day I did a fasciotomy of an upper limb, and I knew I was coming back, so I didn't do a layered closure, but I did approximate the skin so that it did not retract and I could close it on another day. So I'm here, I do 1, 2, that's a surgeon's knot. Now, I know it's gaping, so I don't need to see it open before I do a trick to keep the tension. So I put my index finger under the long suture, I put the short suture over to make a cross, and I press where they intersect. That keeps the tension on the knot. You pull the short suture through the loop, take the tension back on the short suture, take your finger out and close. Boom. It's all about control. It's all about using techniques to assist yourself. Let's do that again. See if we can get the light a bit better. So we're going here, across. Yeah, I could go across in two, but I'm going to do it in one. Palm my forceps. Leave the short end slightly longer than you may do for your normal tying. So one, I need to show you the logo because you know it's a branded needle holder right here by MedSync. 1, 2, that's the surgeon's knot. Close the wound. It's under tension. So I'm going to bring my hands in a little bit. Put my index finger, that's holding the long suture, under, like so. Put the short suture over to make a cross. Hold the tension. Go under the loop. Grab the short suture through the loop. It's still closed. Take the short suture and lift up. That holds the tension on the knot. Take your index finger out and pull. And then a reef knot. And then a reef knot. And like I said, there are a number of reasons why you might need to do this. You've got a wound under tension. I'm not planning to do a layered closure on this sitting because I'll give you the example that I had this week. Did a fasciotomy of an upper limb, and you make your incision something like this, then you come around this way, the Henry approach. You want to, although you open all the fascia to release the muscles, you want to keep your important structure like the median nerve covered, and you want the skin to be close to each other, the skin edges to be close to each other, so that when you come back in a couple of days to formally close the skin, it's possible to, because if you leave the skin ajar and apart, it gets stiff, inflamed edematous, and you will not be able to close it. It will lose its elasticity. You might not be able to close it anyway because the muscle is bulging, but if the muscle is not bulging and too edematous, in a couple of days, you might be able to close the fasciotomy wound. So you might have skin that's under a bit of tension, so you just want to tack it together. And this is a way to hold the knot when you're doing that, so that the skin edges are reasonably approximated, but it does not change the fact that you need to put something in deep here long term to take off the tension and to obliterate dead space. If you don't obliterate dead space, you get fluid in there that can be seroma, hematoma, and they are all mediums for infection. Palm your forceps. We'll do it one more time. 1, 2, that's the surgeon's knot. Lay it square. Bring your finger in and under, this on top. Hold the tension on the knot, go under the loop. Index finger. Take the tension off and onto the needle holder with holding the short suture, and pull. And 1, that's a reef knot. And 1, that's a reef knot. You always wrap between the long and the short. Don't put it behind the long and wrap. You always wrap between the long and the short. Lay your needle holder in between the long and the short. Wrap towards the short, grab the tip and pull through. If you don't grab the tip and you grab further down, this is what happens. The suture gets stuck inside. And then you have to do this, and it's a waste of time. And if it's your first knot, sometimes you have to undo the whole thing. When you get stuck, then you tie it, it gets in the way of the knot, so you haven't got a secure knot, then you have to do this. It becomes a bit of a faff. As I mentioned, if you are using a monofilament, it's between 4 and 6 knots. If you're using a braided suture, it should be 3 or 4 knots. On skin closure, usually 3 or 4 knots will suffice, whether it's monofilament or braided. So we've covered the instrument tie with the surgeon's knot, the instrument tie reef knot. So the surgeon's knot is 2 revolutions around the needle holder, around the tip. The reef knot is a single revolution on the needle holder around the tip. The needle holder lies between the long and the short suture. You grab the tip of the short suture and pull it through. We've covered how to retension your surgeon's knot. The first technique, which we'll just summarize, is to slide the knot to one side. So 1, 2. Keep the tension on the long suture, slide the knot to one side. The other option is if your wound's like this, to retension it, lay a slip knot, which is not a secure knot. The short end comes back to where it came from, the long end goes back to where it came from. So do a reef knot, which is 1 revolution. Short suture, you pull it until the wound closes, and then you pull the short suture, the long suture when you're happy. And then you complete your knots with reef knots where your short and your long end of suture alternate like this. And as I mentioned, don't grab it close to the knot, because then the suture will get caught and then get in the way of the knot. You want to take the suture at the short end at the very tip and grab it at the tip. Put everything into one hand, forceps are palmed, flick this down. There's just no reason why you wouldn't do this, unless you have a Mayo Hager needle holder where it has scissors in it. But you can cut your own suture accidentally when you do that, so, you know, it's pros and cons to all of it. So, I'm gonna do that trick I showed you one more time on retensioning your knot. You're holding the tension on your knot when it's gaping. Okay, again, so swage is there, body is here. Grab it here and pull the packet away. Keep the needle within your view. Go in at 90 degrees, follow the curve. Don't grab the swage, don't grab the point, grab the body. So I'm actually not grabbing the tip. I've got the needle body between the 2 prongs on one side and the 1 prong on the other side. Pull it through. So do a surgeon's knot, 1, 2. Put your index finger under, put the short suture over, keep the tension between your thumb and index, go through that short loop, pull it through. I've still got my wound closed, I can see that with my eye. Take the tension with the short suture and close. Then you do the reef knot, so you can, suture is now really long, so I'm going to shorten it. Again, this technique wastes a bit of suture, but you know. When you're tying your knot, what you'll notice is that if you just bring your hand down, it makes the curve for you. So you don't actually need to do much in the way of maneuvering. Just let some tension go and you can literally put your needle holder through the loop. Just like this, and that's with all sutures. So it doesn't have to be, what you see sometimes is this kind of tumbling like you're about to do a backflip, handspring, somersault, back tuck down a runway, you know? It's just a maneuver where your hand drops and you wrap. Keep your elbows to yourself and then you cut like so. So now we need to do some hand ties. Hand tying is really important. Before we come to hand tying, we need to do things backhandedly, don't we? So palm the needle holder like so. Let me just adjust this a little bit. You go, how does it change if you're suturing backhandedly? Let's see. Nothing really changes. If you've got any questions, feel free to post them in the chat, by the way. 1, 2, still need to do square knots. If you need to do it at depth, you slide your index finger down the long suture and pull. My knot is gaping, so I'm gonna do a slip knot. Now I'm gonna tighten it. Now I'm gonna tighten it. Something that I always see my juniors doing is they do their suturing like under full tension. It looks like it's a physical competition. It's not necessary. When you drive, if anybody drives a manual or has driven a manual before, your driving instructor usually tells you when you first start, you kind of make the gear changes really aggressive, but actually you can do the same thing by pressing the clutch and just moving it down really gently. Same thing with suturing. It's just between index finger and thumb. It's not a strength competition. You just want epidermis to epidermis, dermis to dermis. So you do a 1, 2, you pull, just my 2 fingers pulling it. It's not my whole hand and fist and all my muscles and my interossi, my lumbricals, and then my FDP and FDS all kind of pulling at full tension. It's just my 2 fingers pulling so I get approximation and I tie. Just thought I'd give you some anatomy there of the hand for good measure. And cut. So we now need to do some hand tying. So what I'm gonna do is I'm gonna get a shoelace and I'm gonna show you how I practice hand tying for the early few years of my career. It's really important. And I did indeed use a shoelace to practice, and I had shoelaces all over my apartment when I was a core trainee in the northwest of England, just hand tying when I walk through a door. So you can either put your needle holder underneath a skin pad, you can put your coffee there, and that way if you don't do it properly you spill it, and you can do it there. But I like to do it with a needle holder. So needle holder under the skin pad adds a bit of weight, and then I'll do it with a suture. So one of the challenges with hand tying is the size of the suture and gloves, and then obviously blood and all that kind of stuff when you're doing it in reality. So when you hand tie, we're going to do it the way we get taught in basic surgical skills, which is the surgical skills course in the UK, which all surgeons are recommended to do to get some basic skills. But I think the essential surgical skills by MedSync is also very good. And you can see that on our website, and I'll post in the link, and there's a video on our webpage and on our YouTube channel with all these skills. So by all means, have a look, they're free. Like, share the videos. They're all out there so we can all get some good basic skills. You have a short end and you have a long end. I'm gonna come up a bit higher with the camera. Bear with me. So that you can see a slight difference. So we're doing hand ties. We're doing it with a shoelace first. You have to trust me when I say this is short and this is the long end away from me. With your left hand, so we hand tie, this is a 2-handed hand tie the traditional way. You pick up the short suture with your left hand between index finger and thumb. Your 3 fingers are palm down and you flip over. You keep the short suture between thumb and index finger. The suture runs down your hand. You take the long suture with your index and thumb and run it down the same hand. Positionally, I've got index and thumb holding the short. Let me give you some light. And then I've got the short suture, the long suture running in parallel. Short suture runs up my hand, long suture runs down. The key to 2-handed hand ties is one suture always has to go up, another suture always has to go down. But it started like this. They always have to swap position when you finish. So come up, this one comes down. You bend your index finger over the long suture, under the short suture, and squeeze between middle and ring. Let go with your index and thumb, pull it through, and then retake it with your index and thumb and pull it. The short end is now up, the long end is now down. I'm gonna come back around. So I was like this, now I'm gonna come back down. This time, the short suture, so I was like this. I turned my wrist around and up, palm up. I slid my thumb down the short suture to hold it between the thumb and the ring, and opened the middle and ring finger. So it's like so. That's now going down my hand. The long suture now goes up those 2 fingers you flex the middle over the long suture, under the short suture, and squeeze. Let go with the thumb, put it through the loop. You lay it down and go back to the original pincer grip. For people that have got this, I'm going to go a bit speedier, and then I'll go through it again. Turn up, this comes down, flex the thumb over the long, under the short, bring it through the loop, pull it. As you do that, your index and thumb take the short suture. You turn your hand up, slide your thumb down, open your middle and ring fingers. The short suture now comes down your hand, the long suture now comes up. Flex the middle over the long, under the short, squeeze. Once you've squeezed between two fingers, you let go with your thumb and pull the suture through the loop. Again, if you've got any questions, post it in the chat or leave a comment if you're watching this on replay. Then you come back up. And before I walk through any door, I would do this over and over, and it becomes less of a stepwise procedure, and you carry on. Ooh, that was a bit of a fumble, wasn't it? And up and down. And then you look at your knots, and it looks like a braided bunch of figures of 8. So that's how I would do it. Most of my doors would have a shoelace from an old shoe. I like a shoelace because you can also undo it, and if you really want to add extra clarity to whether or not a square, you can make half of the suture one color and half of the suture another color by just dyeing a white shoelace. But it's not necessary, just to, you know, make things a bit fruity for yourself. So surgical skills are things that you have to practice if you want to get better. If you don't practice them, you won't get better, and you need to practice them before you do things in real patients. You never know when opportunities are going to arise, so you want to stay ready so you don't have to get ready. I'm sure you've heard that phrase for other reasons, but I think it applies to surgical training as well. I'm going to do that again, but this time I'm going to do it with a actual ligature. So this is, we'll do it with this. So it's a 1 suture. I think many people actually would do a one-handed hand tie, and that I'll show you afterwards. But so you have a short suture and a long suture, same principles apply. Lift up, come down, squeeze, and pull. Turn your hand up. Have one coming up, one coming down. The short one's coming down, long one's coming up. Squeeze and pull. And when I say squeeze, I mean you really squeeze. You don't want this to be able to come undone. Turn your hand up, squeeze, and pull. So one suture is always coming down, one suture is always coming up. As you come up, you do the throws, and then you keep going. And obviously you see some people doing them very, very quickly because they've been doing them for so long, and that's fine. And you see I lost my direction there as to who was square and who wasn't, who was going up, who was going down. So I think it's important to know how to multitask when you're doing these things. So I'm keeping an eye on my left hand and who's going, whether it's going up or going down, to make sure that each time I alternate. And then this is how you would do the one-handed hand tie, which I think is a bit less fiddly, and probably why people can do it so quickly. But I'll show you how we do that on a shoelace. So let's have a look at our knots. Let's have a look, let's have a look, let's have a look. So for the most part, they look pretty square. It's a bit loose there, it's a bit loose there, a bit loose there and there. And that's what you don't want when you're tying structures. Why would you hand tie? Because you can have more control on the tension. and that's important. So that was the two-handed hand tie. The one-handed hand tie essentially is just using your left hand to do all the work. So same thing, long and a short suture. Let's zoom out. Again, if you have any questions, post them in the chat, leave a comment, share this with your colleagues, share this with friends, just so that we all can learn and be better together. So grab here, turn up. Same thing applies, you pull it through. But this time, you do here, you just come there, and you're just pulling. You keep this hand still, and then it's just a one finger job. It's just a one finger job. My suture is now very short, my shoelace is in the way. So we're going to switch to doing it with the ligature. It's typically a vicral suture. And again, you do this typically around a vessel. So I'm going to do a one-handed tie with this. So I think it's a bit easier when you have sutures and gloves to do a one-handed. It's a bit quicker. So let's do it as we did at the beginning. Palm down, pick up the suture, turn up, run the long suture down. Everything really kind of happens over these three fingers. Flex the middle, over the long, under the short, and squeeze. Keep the tension on the long suture and your index finger. So hold the suture here, you come up. Index finger goes over the long, flicks the short suture back through the loop like this, and then you grab it and pull. Come up and pull. So the long suture just moves up and down, up and down. Everything happens in the air, and typically you'll be tying things under at depth, so you have to slide your finger down the suture till it ties. And the test will be whether I can move that knot when I finish, the one that's around the needle holder hole. And this is when you then see people, flying at speed. You only need 4 to 6 knots, except for if you're doing a drain. But this is how I would practice it. You just flick it through. So you come up, you squeeze, you pull. Come up, come into this position. Might be a bit short for me now, but we'll try and get one more. Flick it through and grab. All right, shall we have a look? Can I move it? A bit, but it's got a lot of resistance, which is great, so I think it's a good suture. I think it's a good knot. And we have a look at the quality of the knots under some serious magnification. So the ones that are important are these ones. They're nice and tight. There's a slight gap there. That's great. So that brings us to the end of our knot tying session. What have we covered today? We've covered the surgeon's knot, which is 2 revolutions around the tip of the needle holder. We've covered the reef knot, which is 1 revolution around the needle holder. We've covered the slip knot, which is when you do your first knot. The short end comes down, the long end goes up, or vice versa. And then you do your next knot to retension your wound. The short end comes back to where it came from, the long end goes back to where it came from, but you pull the short end first and the knot will tighten, the wound will close, and then you can pull the long. We did the holding knot, where you do your surgeon's knot, keeping the tension on the long one, you slide the short one away from you. We did a hand tie, the key being you have a long thread and a short thread. They have to alternate their position. We did that a 2-handed hand tie and a 1-handed hand tie. And we revised our economy of movement with scissors and then palming the forceps when you're tying on knots. An example I gave was I was in A&E yesterday and I was suturing a thumb. My surgical field wasn't any bigger than this, and I didn't have space to keep putting everything down. It would have fallen off the edge of the sterile table that I set up for myself. So keeping my scissors here in my sterile glove meant that I didn't have to keep looking for the scissor. I didn't have to desterilize the scissor. Everything was well findable and my economy movement was good, so I could do the procedure quicker. And then my forceps were in my hand. I didn't have a scrub nurse to cut for me. I didn't have Mayo Hayo scissors to cut whilst I sutured, so this was the most economical way to do it. So thank you for joining today's live session. Feel free to drop a comment, leave a question in the chat, subscribe, share with your friends, and we'll see you next week for another live session. Just drop the giveaway there. See you then. Take care. Bye.